Hi, hello everybody. Welcome to another episode of Intellectual Calisthenics. Today I am truly honored to have as my guest Dr. Latika Gupta. Now some of you have heard Dr. Latika Gupta before, and she is extremely passionate about her subject. She's a clinical immunologist and a rheumatologist. She wears many different hats. Some of the chief ones are she's an associate editor at the International Journal of Rheumatic Diseases. She's a social media editor, Journal of Clinical Rheumatology and Indian Journal of Rheumatology. And she is an assistant professor at the Department of Clinical Immunology and Rheumatology at the Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow in India. And it's a very prestigious tertiary care institute that Dr. Gupta works at. And today, what we are going to talk about is something very interesting. So, given the ongoing coronavirus pandemic, what recent studies have shown that there is a difference in mortality amongst women versus men. So, what we are going to talk about today is how much of these differences can be explained with respect to immune system differences, and who else but an immunologist to talk to us about that. Dr. Gupta, will you just introduce yourself a little bit and how do you juggle all your different hats?
Thank you, Dr. Carr, for inviting me today and the very kind introduction. Yes, I'm a clinical immunologist and a rheumatologist, so basically a clinician scientist, and dealing with the immunologic basis of rheumatic diseases primarily, but also trying to understand the immune basis of most other things. And as we go deeper, we learn that immunology is the core basis of most of the other diseases as well. So yeah, happy to discuss this topic today. Could we have the slides,
Yes,
please?
I am going to start with the slide sharing. Just bear with me for a minute. Okay, so this is our topic. This is the two of us. This is just a basic overview. So Dr. Latika, are you able to see my screen?
Yes.
Okay. And okay, I don't have the option to do a side-by-side sharing. So I think what I'm going to do is just to keep the distraction away, I'll keep our this thing away. So this is basically an overview of what we'll talk about. We have a lot to discuss, and I'm really excited to have Dr. Latika Gupta's input here because she's, after all, an immunologist. And suddenly, with the ongoing coronavirus pandemic, all of us have had to upgrade our knowledge of immunology in a great way. So these are different areas we will address today. So the first thing that I need to get out of the way is, number one is the reported mortality from COVID-19 is about 60 to 70% higher in men than in women. Now, I didn't find a lot of data from India. I went to the ministry's website. They didn't have data differentiated between men and women. But Dr. Gupta, this would be correct for studies from Italy, US, everywhere else. Am I right?
Yes, definitely the mortality figures suggest that it is higher in men and women. And if you look at the global health 50-50 data, then it suggests that although the number diagnosed in healthcare workers, it's more in women, but then we don't really have the ratios with respect to the number of women who are healthcare workers, because a lot of nurses and the
Yes.
other paramedics may be women.
And another factor that we need to bear in mind is infection rate is not more in women, I think. It's about the same in both, but mortality is higher, right? So one important factor that we want to get out of the way right away is the difference between sex and gender. Now, I was formerly an OBGY, and we never really, back in those days, we were never really taught a lot about the differences, particularly in respect to cardiovascular disease, mental health challenges, autoimmunity. Why is it that, more women are affected by all that? And cardiovascular disease in women is very, very different from what it is in men. So sex is biological. So there is an X chromosome and a Y chromosome. Women have XX and men have XY. And gender is actually a cultural, social construct. So there are some factors which are important with respect to gender. So things like, are women, number one, do they get less access to healthcare? That is one of the major factors. Sometimes women don't talk about their illnesses as much. So is it that they wait until they're more severely ill? not in COVID-19, in other conditions as well. So those are gender related issues, and sex is, basically, so what happens is, and this was so interesting, Dr. Gupta, when I was looking at the data. So the X chromosome, as you can see in the picture, is of course much bigger than the Y chromosome. Now men have XY, one comes from the father, one comes from the mother. Obviously, the Y has to come from the father, and women have two X's. So the question here is, given that men have one X less and women have one X extra, so what happens, number one, to the extra X chromosome in women? And then I'll come to the genes that are present in the X chromosomes and Y chromosome. So, Dr. Gupta, will you explain what happens about the inactivation of the X? Because given that, this is so interesting in relation to autoimmunity as well, and we can go down many different rabbit holes. So, will you
Yes.
explain a little bit about the inactivation of the second X in women?
Definitely, this is a very interesting concept, and the underlying basis of a lot of disorders, especially of autoimmune origin, because this X chromosome has more than 1,000 genes, while the Y chromosome is really deficient in terms of the gene number. And normally, the two X's are not really required for functioning. So even in women, there will be like preferential inactivation of one of the X chromosomes. So that is known as lionization, or one is lying in the dormant state. And sometimes so like we are all along a spectrum, even our genetic composition is along a spectrum. So sometimes particular alleles on one arm of the X, it may be poorly functional, or functioning less than normal. So suppose there is an unfavorable lionization, that is, most of the people, the right or the healthy allele gets inactivated. Then even in women, sometimes they can manifest with disorders which are normally present only in men. While in men, since they have just one of it, once that is knocked off, then automatically they manifest with the disorders because they have just one copy, anyways.
Yeah, as you rightly pointed out about the 1,000 chromosomes, genes in the X chromosome, and I think the Y chromosome has about 50. So am I right in understanding that a lot of the chromosomes on the genes on the X chromosome are related to the immune system?
Yes, in fact, recent studies have shown that the responses to viruses, they also may differ in men and women based on a lot of important genes, because the virus, when it enters the cell, some of the innate immune responses, like the toll-like receptors, we'll talk about it in a bit. So some of them are on the X chromosome, and since men have only one copy of the X, if there's any polymorphism, like recently a rare disorder was described where TLR7 polymorphisms led to severe disease in young males who are otherwise healthy. And this is not just limited to COVID-19, but also in HIV. They've shown very common polymorphisms, which are spread out across the population and maybe lesser studied. They may predispose men to the disease, especially the acute viremia, the initial phase when the virus tries to enter the cell, while women may like mount a more robust immune response and may be relatively more protected just because of
Thank
the
you.
X chromosomes.
So just for, a lot of people may not be aware of what is a polymorphism. So basically this is like, it's not a genetic error. It is essentially more like a typo in the sequence of the DNA sequences. So the CTAG, those may get a little switched here and there, and that can change the way a particular, something functions in a different way. So that is basically an easier way to explain the polymorphism. So the other thing is, what I wanted to bring up is the ACE2 receptor and its relevance to COVID-19. So this is something we've been hearing a lot about. So Dr. Gupta, will you just explain very simply for non-immunologists what it means, that why are we so concerned about the ACE2 receptor?
Right. So this receptor has been, I think, suddenly shot to fame after its association with COVID-19. Normally, it is a receptor of angiotensin converting enzyme. So in relation to the renin-angiotensin system, and we have blockers against this used as antihypertensive, which a lot of you would be familiar with. So this receptor mediates the entry of the COVID-19 virions into the cell, and thus it becomes very important. And recently there has been some evidence, which maybe we'll look at in the next slide, where estrogen and even the androgens for that matter may influence the expression of this receptor. So
Yes.
once its expression is modulated, then probably the entry of the virions into the cell may be affected, and it may result in differences in infection rates or the severity of the disease.
Thank
So
you. So, yeah, I'm just going on to the next slide because that is your slide completely. So, before we go on, as Dr. Gupta rightly pointed out, estrogen has a very big impact on the regulation of ACE2. But there are other factors as well, and ACE2s are present in other tissues. But in relation to COVID-19, the lung is important because of, it's basically a respiratory infection, at least to a great extent. But of course, it impacts a lot of other organs. The other major factor that is involved with this is the presence of people with diabetes have had worse outcome. So diabetes, both types 1 and 2 are also important. However, for today's discussion, we are not going to focus on diabetes and all the others. So, Dr. Gupta, over to you to explain what this slide is telling us. So, this was an in vitro study, am I right?
yes, this is one of the in vitro studies which instantly brought to light this very important concept that estrogen may downregulate the expression of AC2 receptor. So in this experiment, the authors took bronchial epithelial cells. So they tried to create or mimic the lung tissue in vitro, and after application of estrogen, as you can see, the copies of AC2 receptor, that is, they measure the RNA levels and compare it with another um, gene to see the expression. And as you can see, it was significantly downregulated. So estrogen may influence the expression, while this TMPRSS2. This is the other receptor which mediates entry of the virion. So this one was not affected, while AC2 was significantly affected.
Mm-hmm.
And although we have to take this with a pinch of salt, because the N here that we're talking about is just 2, and it's in vitro, and the level of estrogen, the estradiol, which was used, was comparable in vivo to pregnant ladies.
Mm-hmm.
But then we'll also talk about pregnancy in a bit. And
Yes. So
so
just one clarification. So an in vitro study means it's done in a laboratory in a petri dish, not in human beings. And the other thing is, as Dr. Gupta pointed out, it's just a sample size of 2, right? And the beta estradiol given in was at the dosage of pregnancy. Now, pregnancy hormones is a very different ball game, and pregnancy hormone levels are also not what is usually present in women. However, it still goes to show that estrogen does have effect on the ACE2 receptors. So the next thing is, this is in, again, what are the sex differences in immune response to COVID-19? So, Dr. Gupta, this is entirely your slide. It is extremely busy. And remember that there are a lot of people like me who still struggle with immunology and who still have to figure out what is a TLR and what is a DAMP and a PAMP and all of that. So, in simple terms, what are the sex differences and how would they be relevant to COVID-19?
yeah, so when we talk about this slide, this wonderful commentary in Nature, it gender versus sex. So here we're talking about the sex part of it, or the biologic differences, how constitutionally men and women are different, and how that may be influencing the virus and the disease in women. So here, as you can see, there are various mechanisms and so many hypotheses floating around. It's called the physiologic hypothesis. And you may wonder, is it the estrogen? Is it the other hormones? Is it the X chromosome? And it may be a bit of everything, as you see here. So we just talked about the virus entry. So AC2 receptors, they are differentially expressed in women, and there are more studies underway to look at that in vivo. And then, of course, the viral sensing mechanisms may also differ between men and women. We talked about the TLR7. So this is the innate immune response. Whenever a virus enters a cell, then there's this acidic vacuole where it enters, and then it stimulates certain segments of the DNA and receptors, which eventually lead to mounting of an immune response. And this is the viral sensing machinery. And a lot of these genes here, they are on the X chromosome. So as we talked about it, there can be differences between men versus women. And so this is where the entire game begins. And then this translates into the downstream immune responses. So we have the first hit against the virus, which is the innate immune response, and that includes the macrophages and the other cells, neutrophils and monocytes. So people have shown that men versus women, there are clear differences. Women mount a more robust immune response, and again, I come to the interesting concept of gender versus sex. So people have tried to eliminate the behavioral aspect of it, because whenever you do a study in real in the population, it's very difficult to distinguish what is what. So
Yeah.
they have shown that in infants, where there is a brief surge in the estrogen levels from the mother, so there they have shown that the innate immune responses and everything, they mirror those of post-pubertal women. So there's no behavioral difference in infants.
Hmm.
And that is what really seals the case, that it is a lot of it may be hormones, apart from the genetic composition, of course.
That is
And
so
then,
interesting. Yeah. Sorry, go ahead.
yeah. And in fact, that's not just being shown for COVID. So this hypothesis has been around. The prominence is being much more with COVID, but there's been very interesting studies in other infectious disorders which have shown that clearly women are more protected, except for the autoimmunity bit. So of course, everything
Yes.
comes with disadvantages, and the adaptive immune response comes into picture later. So whenever there's a pathogen, we start fighting it, the first line of defense and the second line of defense. And eventually we have antibodies which are formed, and which also helps regulate the memory, so that next time we get the virus or the infection, we can fight it faster. And we will see in the later slides how these are more robust in women as well. So maybe
Thank
a bit
you.
of everything. As you can see, that women may be more protected for various reasons.
Hmm. Would you say a little bit about the cytokine production and the chemokine production differences between men and women? One slide later, we have clinical studies showing the differences. And one more question I'll ask you is about so what does the NK cell, the natural killer cell, do? And I have a reason why I'm asking you about this. We'll come to that later on. So what does the
Yes.
natural killer cell do in relation to fighting a viral infection?
So NK cells are the prime line of defense against viruses. So of all these cells in the innate immune machinery, the NK cells are particularly important because they are the direct fighters against the virus. They kill the cells which are infected with the virus, and maybe the first line of defense. So differences in the NK responses may really translate into high acute viremia. And people have shown differences in the NK, and also the CD8 cell is also one subtype of the T cell that is a brother of the NK cell. So together they mediate the same process. And there are significant differences in the genders, and also divergence in that with respect to age. With increased age, there are changes in these two cell types.
Yes, that is, thank you so much for that. Just one comment I want to make on the NK cell. So sleep loss, or rather sleep deprivation, so sleeping less than 6.5 hours has shown in studies to reduce NK cell activity dramatically. So one more way of, increasing resilience, if that is what you're looking at, is, to go to bed early and get your enough number of hours, so 6.5 to 8 hours. And Dr. Gupta and I are both actually sleep evangelists. I don't think, Dr. Gupta, you stay up late, do you?
No, I don't.
You're an early morning person, considering that this is very early in the morning in India. So I don't think we'll have time to go into the B cell, T cell responses in COVID, because we'll run out of time, a lot of other things to talk about. So in this particular one, I was asking about the cytokines. So this was a study where they actually looked at COVID-19 patients. So male patients had higher plasma levels of IL-8, IL-18, along with more robust induction of non-classical monocytes, whereas female patients mounted a significantly more robust T cell activation than male patients, which was sustained in old age. We are coming to age a little later on, because one of the things is with older age, it is immunosenescence. So older people were having a higher mortality. Now, this difference in IL-8, IL-18 and all that, so what would it mean? What does IL-8 mean, and what does IL-18 mean for, in terms of a response?
So here we're talking about two different concepts, as you rightly said. One is the innate immune response, so the cytokines. Whenever we have any sort of infection, we mount immune responses. Our body does that, but some of them may be protective. but some of them can also be counterproductive in terms of they can cause more damage to the host than to the pathogen. And thus we talk about these cytokines like IL-8. Ideally, it is aiming to recruit more neutrophils, so promote more inflammation. And IL-18 is more of an interferon responsive element, so again, antiviral response. But we saw in this study, this paper from Yale, which was published in Nature recently, the authors took moderate disease and they found that men had more cytokines. So clearly these men had also, those who had more severe disease had more robust cytokine production. And this may explain why there was greater decrease in cardiac activity and how their entire course went downhill in the group B. So they took follow-up samples and they studied this group. And the other thing which we're talking about is the T cell, which is they particularly talk about the CD8 T cell, which I mentioned in the previous slide, which is very important in clearing the virus in the acute phase. And these responses wane off faster in men than women. And that may explain why there is greater risk.
So this is something that, very interesting, because a picture always speaks louder than words. So will you just, I think, basically explaining what you've been saying so far?
So another different arm is the B cell. So once we have the virus, we get the infection, then we develop immunity against it. So that's where the B cells come into picture and antibodies are formed so that next time we get the infection, they can be cleared off more efficiently. And even here, the responses are fundamentally different in females. So like people have shown that the aggregates of B cells, the plasma cells within germinal center. So within lymph node, we have aggregates of B cells and T cells, which together help in production of antibodies. And you can see in this picture, the germinal follicles where the antibodies are formed, they're much bigger in women than in men. And this is from mice, but people have also shown it in humans.
Mm-hmm.
And thus the antibody responses are more robust in women. And although this may come with its own problems, so more autoimmune diseases, especially antibody-driven diseases.
Yeah, and more mental health challenges as well. So next is, we've been hearing a lot about, people dying of clotting, thrombosis. So what is different about thrombosis and COVID-19 in relation to mortality or morbidity and all of that?
So this is a very interesting and important concept. To start with, we thought that COVID-19 is just another viral disease and it is just causing inflammation in the lungs and that's about it. But now it is deeply concerning to see that when people have done autopsy studies in the on 40 to 60% and severe disease 80 to 100% of people would have microthrombi in the pulmonary capillaries and there'll be infarcts. So clearly that is changing how we want to manage the condition and also how we look at it, because biologically there are a lot of differences in thrombosis between men and women. So all the thrombotic disorders, you look at the arterial disorders like acute myocardial infarction, strokes, or venous thromboembolism, a lot of them, men may be more susceptible, especially when they have other risk factors. And maybe we'll talk about it in a bit, why it is so.
Mm-hmm. So this was very interesting. You talked about the sex-based differences in platelet function. Now, am I right in understanding that COVID itself has changed platelet function in many people?
So yes, people have shown that a recent paper in Lancet, it showed that COVID-19 eventually is an endotheliopathy.
Mm-hmm.
Contrary to what we previously thought that it's causing inflammation, it's more, it causes endothelial dysfunction. So there is increased expression of this molecule known as P-selectin, and that leads to more attachment of platelets and RBCs and rolling transmigration, and then these move inwards and then they can aggregate and lead to a thrombus formation. So it's the inciting event in the formation of a thrombus. And so people have shown that what brings platelets together is this von Willebrand factor, and it has been shown that the levels are higher. The multimers of von Willebrand factor, they are higher in COVID-19 affected men than women, and men also have more thrombosis and all the associated molecules in the cascade. So I will not probably go into the jargon. So there is this TXA2, PGI2, and then the fibrinolytics our natural coagulation system has some processes in place to lyse those clots which are formed. So they are lower in men and higher in women. So,
Okay.
so these things become very important with respect to COVID, because these differences in platelets in general, they have been shown disparity between the genders. And this is primarily related to the platelet function. So P-selectin levels, they are higher in men. 1 milligram multimers, they're higher in men. If you look at the clots, so people have done studied the fibrin clots in acute myocardial infarction, and it has more fibrin. It has more von Willebrand factor and in men as compared to women. So this may change how we look at things, and especially when anticoagulants are being
Yes.
considered in a big way for management.
Yes, we'll come to that. That was a very interesting point you brought up when I was going through the slides. So another important thing is women have a hormonal milieu, which is like not the same throughout the menstrual cycle. And the other thing is it's not the same throughout their lives as well. So pregnancy is a state where we would like there to be more clotting because we don't want women to bleed to death, versus at other times having a more, less clotting is better for long-term disease. So the other factors that you mentioned is a risk for venous thromboembolism in women. Again, it is dependent on so many other things like, use of birth control pills, which is not as common in India. That is related to higher risk than obesity itself. And the other big thing nowadays, I think that is irrespective of men or women, is the continuous sitting. That is also another big factor. And you mentioned about pulmonary embolism, stroke risk. So stroke risk in relation to, again, I'm not going to spend time in that. So next comes the response to seasonal influenza vaccines. Now here we are not talking about COVID vaccine because the vaccine is not out yet. But if we look at, response to seasonal influenza vaccines, what is it that we are seeing? So many studies have shown this, that women have antibody response to seasonal influenza vaccine are at least twice as strong in women than men. But Dr. Gupta, I was very surprised to read on your slide, this next one, that greater immune response doesn't imply protection. So would you explain a little bit about that?
So yes, definitely people have shown that the immune responses are more robust. So they're more B cell proliferation, particularly the B cells, which are generating antibody responses, the plasma cells. And we also talked about the germinal centers in the previous slide. So they are more robust in women, but in this study in mice, they showed that the protection, so when they looked at the weight of mice or the change in body mass in the vaccinated versus unvaccinated females, even though the antibody levels were higher in the female mice, the weight did not really change in men versus women. So because the primary line of defense against viruses is the CD8 T cell. So
Okay.
that is what determines it's the first frontier where the virus has to fight to get into the cell, and this is like the machine gun of our body. So it has these perforins, granzymes, and various cytotoxic granules. So as soon as it finds any cell which is infected by the virus, it will bombard that cell with the granules, and this will drill holes into the other cell and lyse it. So cell suffers death. So CD8 T cell cytotoxicity.
Thank you. So next we move on to COVID-19 during pregnancy. Dr. Gupta, over to you.
Yes, this was something which was deeply concerning for everyone when COVID-19 came. In fact, a bunch of my own friends were pregnant that time, and we were like, what to do now? But this has really been gone around in a direction which was not previously anticipated. So first I'll show you the CDC data. So total of 20,000 cases, 44 deaths, so translates into 0.2%, which would be lower case fatality rate than the average population. I'd say that with a pinch of salt though, but then if we go deeper into the evidence at the next slide, we see that there are a lot of hospitalized cases and a lot of ICU admissions. Obviously, there's a lot of concern surrounding this group because COVID is such a morbid disease. And this is data from the United States. If we go on to see further in the later slides, initially people anticipated that there will be a lot of deaths, there'll be a lot of poor outcomes, and whether the neonate will get COVID-19. But I just went through this recent study which has prospectively compared COVID-19 mothers with a historic cohort of COVID negative women and there was no difference in outcomes.
Mhm.
So, except the ICU admissions. ICU admissions could be affected by a lot of factors, so they have not really gone into it. But neonatal, this is something very positive and again fits in very well with our estrogen hypothesis, isn't it? Because the
Mhm.
estrogen levels are also higher in pregnancy, even though it's more progesterone dominant condition, but even the
Mhm.
estrogen levels go up.
Yes, and particularly levels of E3, the estriol, which is not really very high, and it's a relatively weak estrogen in non-pregnant women, but it's what in our world we call a safer estrogen. So there are three different types of
Yeah.
estrogens: E1, E2, E3. E2 is the 400 different functions of estrogen in the body. E1 is the estrogen predominantly present in postmenopausal women, and the one that is associated with high risk of breast cancer. And E3 is predominantly present in pregnancy. And interestingly, there are studies of using E3 in multiple sclerosis. Anyway, we're not going there. One question is, so therefore, as I understand it, we still don't know if there is any vertical transmission of the SARS-CoV-2 from the mother to the fetus. So it does, whether it goes across the placenta, I think we still don't have definitive information about that. Am I right?
Yes, people are still trying to find out, but the more interesting bit is when we talk about so much of thrombosis, and
Mhm.
people have demonstrated thrombosis in placenta. People were anticipating that there will be thrombosis in the placenta as well, but there was this small study, although, but here they have looked at various placenta in the third trimester, and there was no sign of thrombosis, which is again a
That
very
as of
thing.
as a former OBGY, that is very exciting because we don't want the placental thrombosis because that
Yeah.
impacts the fetus in a very bad way. So next is a little bit about hormones. I am not going to go do a deep dive because this itself is like my associate and I have done a longer one of this. So this was a study from China where they looked at women's sex hormones, and these were the people who had COVID-19. So pre and postmenopausal women who were not on birth control pills, not on hormone therapy. So they measured levels of estrogen, progesterone. AMH is an anti-Mullerian hormone, follicle stimulating hormone, luteinizing hormone, prolactin. So these are all the hormones that were measured. What they found is premenopausal women had a milder severity and better outcome of COVID-19 compared with age-matched men, and higher E2, so estradiol levels were correlated with lower IL2R, IL6, IL8, and TNF alpha. So, Dr. Gupta, one thing is, does that last sentence, higher E2 levels associated with lower all of those interleukins and TNF alpha, is that something good or that's like neutral or it's not good?
Yeah, again, we come to the same thing. Like we saw that in men, the interleukins were higher. So we might want to think a good immune response is always a good thing. But people have shown that a sudden cytokine storm, it can really affect the myocardial contractility. It can lead to a shock-like state for your
Hmm.
body. And
Yeah.
that is the basis of the cytokine storm syndrome, where there are adverse effects related to the virus, and that is the cause of death in a large proportion of people. So this is definitely a good thing over here because a more
Okay.
regulated response.
So one comment from someone who deals with hormones in women is premenopausal women we cannot assume that they'll have normal levels of estrogen because the perimenopausal period, that is the period before the final menstrual cycle, can extend from 8 to 10 years. So the fact that they measured the actual levels of hormones and particularly estradiol is much more relevant in this study. And this is again very interesting. Dr. Gupta, you brought up the cytokine storm. Now, recently, I think we don't have time to go into it. They were talking about bradykinin storm and not a cytokine storm. Maybe we're going to deal with that on another video. But do
Yeah.
you think that difference will make a big have a huge impact on how COVID-19 is managed?
Uh, yeah, definitely. I did read briefly about it, and again, it will open doors to the same angiotensin renin axis which we were talking about.
Hmm.
Although till now, systematic reviews have not really shown any difference in regulating that axis with the AC inhibitors, because bradykinin pretty much converges onto the same axis.
Okay. So this slide, I just wanted to show, like I had explained before, that women pregnant, menopausal, and as you can see in the follicular, preovulatory, and luteal phases make very different levels of hormones. And the point I wanted to bring out here is women make testosterone as well, but not, of course, as high levels as men. And the other thing is men make estrogen and progesterone too. So the fact is, it's not like it's all men's hormones. Testosterone is men's hormones, and estrogen and progesterone are just women's hormones. It's always a balance of all of them. And each one of them actually has different effects on the immune system, right? So, Dr. Gupta, testosterone and progesterone are primarily anti-inflammatory. Am I right?
Yes, that is true. And yeah, this does translate into some impact on COVID-19 as well.
Yeah, and we'll come a little bit to the testosterone and men as well a little later on. But the other thing is with estrogen, what happens is estradiol has, had different kinds of effects depending on the concentration. So lower concentration of E2, for example, in the follicular stage of the reproductive cycle. So the menstrual cycle it's a cycle, it's not a continuous level of hormones. Can be, so the follicular stage can be pro-inflammatory, whereas the higher concentrations of estradiol during the luteal phase can be anti-inflammatory. That is again very significant because obviously the goal of the menstrual cycle is to, for a pregnancy. So a pregnancy situation is very different versus, postmenopausal women. So that is something that I just wanted to point out. Each hormone is different in its action on the immune system. One different thing is, Dr. Gupta, will you agree with me? This is, if any of you want to read one article, I would highly recommend this particular one, Sex Differences in Immune Responses. In fact, I think Dr. Sabra Klein is called an immunofeminist, right?
Yes, this is very interesting, and it talks about the various ages and how gender really influences autoimmunity.
Yes, I love that paper. So again, hormone therapy in women, I'm not going to go into details because I've done a video on that. And in India, not a lot of women are on hormone therapy, unfortunately. So most people, when I talk about hormones, oh, hormones are bad, they're going to kill everyone. There is a big difference between what was hormone therapy before the Women's Health Initiative study came out in 2003 versus what is hormone therapy today. So hormone therapy then was the kind that increased coagulation, increased risk for cardiovascular disease, increased risk for cancers, versus what is recommended now is transdermal 17-beta estradiol. So transdermal means on the skin. So hormones applied on the skin do not increase coagulation. This is something I am like tired of telling and explaining to people, because very often we'll have patients coming and saying, my cardiologist said I cannot take hormones because I have, hypertension, or I'm at a higher risk for heart disease. Well, it doesn't apply to transdermal estrogens, and estriol, the E3, can also be applied vaginally, which is extremely safe. And the second part, the progesterone component in the hormone therapy recommended now is oral micronized progesterone, which is exactly bioidentical to what your body makes. And that does not increase cardiovascular disease or cancer risk. So just for women who are already on hormones, if you are on oral estrogens and you are on a medroxyprogesterone acetate, MPA, you need to have a conversation with your doctor whether it is relevant for you to switch to a transdermal one. And transdermal ones are available in India. So I'm not going to go into details of this because this is not about hormone therapy. But my point is, hormones, someone is on hormones, you don't need to stop them, because even if you've had COVID-19, or if you think that you're going to reduce your risk, no, getting off of hormones will not necessarily reduce your risk. The only things reducing your risk will be wearing masks, washing hands, and physical distancing, and maintaining metabolic health. Now, men and testosterone, the thing is, so this, again, because this video is not about men, I didn't post the details of it. One is low testosterone a higher risk? And are those, again, there was the other one, which was androgen deprivation therapy for prostate cancer. Were those men doing better? Now, one thing with low testosterone in men in general, that is not a good thing for, in relation to the metabolism. So higher risk of diabetes in men with lower testosterone. And as we know, that diabetes, hypertension, heart disease, these people have done worse. So again, we don't know yet, but interestingly, so again, Dr. Gupta, there are trials going on men, but I've not come across trials going on in women and hormones. So men only, and estradiol 100 micrograms a day for 7 days through a patch applied on the skin. Hopefully the results will come out in November. Then the other one is men progesterone 100 milligram, which is actually a very high dose for progesterone in men, and the estradiol as well. And this will be administered as a sub-Q injection twice daily for 5 days. However, it's not for long. So both these clinical trials are ongoing and the reports have not come out. And as far as I know, I don't think they're doing any studies on women and estrogen and progesterone, I mean, any hormone therapy as yet. Do you know of any trials, Dr. Gupta?
No, I looked up. There were 5 trials, I suppose, and most of them were on estrogen patches. Some of them also gave them once a week for 21 days, and one was on tamoxifen and melatonin, and then some on anti-androgens. So there was one on anti-androgen, I think. Uh, I forget the name of the drug, but yeah, most
So
of
this
them
was
are
in men or in women? 'Cause I didn't find any
it
women.
is in men. Yeah.
Men, yeah. So sex and age differences, this was again something that you brought up earlier. Elderly males are more susceptible to COVID-19. So basically what we found is age, older the age, higher the mortality, more severe disease and all of that. And you talked about the CD8 T cell response, which wanes more with age. So the immunosenescence that we were talking about earlier. So Dr. Gupta, will you just explain this particular slide? What happens to the innate immune response across the lifetime?
So yes, the innate immune responses, they do mirror the hormonal profile. So there is, as we talked about in the pre-pubertal period, there is increased inflammation in males per se, and increased NK cell responses. But when we go to the post-pubertal period, then there's a sudden switch, which
Mhm.
can be attributed to the hormones, and there's increased inflammation in females, as we saw across the slides. But NK cells are something which are still more active in males, and in old age, again, we call it the immunosenescence. So even though the CD8 T cell and all the responses wane, there is more of dysfunctional immune response. So there is again a phase of immunoinflammation, and we see that more in males, and
Mhm.
there is switch in NK cells. So, but we can't really take for the numbers, go with the numbers mentioned here, because it's also about the quality of responses, which can
Yeah.
change with.
And there are so many factors involved in this. Just one comment on this. So IL-10 is an anti-inflammatory interleukin, right?
Yes.
So IL-10 increases in women in older age. So that means they should have less inflammation, right?
Yes, definitely. It's more with age and men.
Okay. So besides all the things that we talked about, the differences between men and women in respect to sex, we haven't talked about gender, obviously. What are some of the other things which we won't go into today apart from just mentioning? One is the sex differences in the microbiome. So the microgenderome is what they have been calling it. And it's not just the gut microbiome, because most studies have been done on the gut microbiome. So people talk more about the gut. However, there is a difference in the microbiome in other parts of the body as well. So back before the human microbiome study came up, Dr. Gupta, I, as a former OBGY, we used to consider the uterus as, absolutely sacrosanct, that there are no bacteria, no nothing in there, no microbes. And now it turns out that it's very interesting how the baby gets the first dose of the microbes and how it impacts their immune system. So yes, there are other things as well besides, hormones and ACE2 receptor activity. However, as clinicians, what we are interested in is what are the things we can manipulate, either with medications or with food and supplements. In my case, mostly. So the gut microbiome, particularly, is something we can manipulate with food. So that is one area which is very interesting, but I don't think we have a lot of studies coming out in respect to the difference in the two sexes, right? The next is about lung function and smoking. So smoking worldwide, I think women smoke less than men. However, what about the sex differences in lung function? That would also have an impact, right?
Yes, in fact, there are entire studies showing even from the formative stages in utero and later how the formation of the alveoli, mucin secretion, the endothelial function. So the lung is an amalgamation of various structures and their functions, and all of these have potential for influence by the gender and by the sex hormones. So apart from smoking, of course, hormones do help in shaping up lung function. If you see, a lot of lung disorders are more common in men. That
Mm-hmm.
has been attributed to smoking. Even for tuberculosis, people have said it may be the behavioral influence because they're more outdoor activities.
Mm-hmm.
And even for COVID-19, one of the theory floating around was that men are more likely to uh, not wash hands frequently.
Yes,
So,
I'm coming to that. Do women take better care of themselves?
so I don't know. I'm tempted to say yes, but then I don't know how much evidence I'll have to support
No,
that.
there is evidence saying that women actually are more in relation to wellness and preventive, health measures. Women are more, they do more of that versus men. And I think another thing which I call the ostrich phenomena. Do you think that ostrich phenomena of ignoring symptoms and things like that is less common in women than in men?
So definitely the societal and social construct would
Yeah.
determine that. Like in India, there's a higher reported COVID mortality in women. So people say it's due to late reporting of symptoms.
Mhm.
So it would definitely impact the outcomes, but I don't know how it'll influence the gender in different countries.
Yes, it'll be different in different strata of society as well. Because again, the thing is probably what would be different is probably if you are looking at, women washing hands and maintaining physical distancing and wearing a mask would be more common. I don't know. I've not checked the literature in that. So, given all these things that we have discussed, do you think men and women should or will have different treatment options? And I'm going to come to your next slide. So, this is something that I know we don't have enough studies to support this, but what would be your opinion as an expert?
Yes, definitely. After reading much on this topic, thanks to you, I am tempted to agree. But to say should, of course, like it's too early to say that because we don't have evidence to support. Everything is very speculative at this time point. But it is a possibility with all these trials. People are thinking on those lines, and even the anticoagulation threshold, because
Yes, I would like you to talk a little bit about that because that is an intervention which is being used at present. So what should treating physicians be aware of when they're looking at a woman versus when they are treating a man? So heparin versus oral anticoagulants, what is being used? Now, Dr. Gupta is actually at the COVID front lines. I am not. So definitely your experience counts a lot. So what would you recommend?
Yeah, right now, like in severe disease, heparin is being used. But looking at the evidence till now, of course, more evidence is definitely needed in women versus men. We need more studies, autopsy studies, and because that's the only hard way to substantiate thrombosis. And we need to establish, especially that placental study, even though it was a like pilot study in a small number of placenta, but this is something worth exploring. How much is the thrombotic burden in women actually? And
Yeah.
because anticoagulation does come with its own risks, although we don't have much data on that either. How much is the bleeding risk in women versus men? So these are things which we need to look at, especially in those who have other risk factors for bleeding or are on other anticoagulation and or have other disorders because these drugs can also have a lot of drug interactions. So
Yeah.
these are the minor things which we need to go into in the times to come.
And estrogen, of course, estrogen trial, high, of course, both of us would say that we do need, and I would say we don't need just estrogen trial, we need estrogen, progesterone, and testosterone and DHEA as well. But basically, we need trials in women using hormone therapy, and particularly the type of hormone therapy, not oral estrogens and MPA. So
Yeah,
those would be another.
Sorry, yeah, it's very interesting. If just a patch once a week can do the job, save you from a deadly disease, then not a bad deal at all.
Well, if you put me on the hormone therapy soapbox, I can talk until kingdom come. So not just in COVID. The other interesting question that you brought up is, will there be more autoimmunity in women post COVID? This is my speculation that there will be more autoimmunity in general, and I think there has been one case of a GBS in a woman post COVID. But what makes you say that there would be more autoimmunity in women post-COVID?
So generally, because women have that kind of a genetic construct, that they mount a more robust immune response. So most of the autoimmunity, the triggering event is something in the environment. It
Yeah,
may be some sort of like smoke or a carcinogen, any kind of antigen. So often
yeah,
it is an infectious trigger, and so COVID-19 also being an infection, there is a reasonable risk that it may trigger autoimmunity, although we don't have evidence to support that yet.
not
So
yet. Yeah, it's still
yeah,
too early.
yes,
Yeah,
we did hypothesize that we'll see more flares in our
yeah.
autoimmune rheumatic diseases, but that has not been really substantiated yet. There are some forms which are having more flares, so we have some emerging data even at our center, but definitely we will need more on that. And
Hmm.
this is something we need to watch closely to be more sure about it in the times.
Yeah, and considering that we're already hearing about post-COVID syndrome of chronic fatigue, fibromyalgia, and all that, and there could be an autoimmune component to that for sure. And
Yeah.
so there are two things here. One is induction of new autoimmune diseases in someone who's never had autoimmunity. And the second is what you're talking about in your already pre-existing patients who have autoimmune diseases that already diagnosed, whether this can trigger a flare. So I think we don't know yet. Vaccine efficacy, again, we don't have data yet. I think we have to wait and watch when a vaccine comes out and it's goes through all the trials. So this is the last slide. So possible reasons for sex differences. And I'm going to stop sharing the screen. I think this is the last slide we have. So Dr. Gupta, your last comments on what are the things so let us say, you have all the funding and all the support possible. What is it that you would like to study in relation to the immune system and COVID-19?
I would definitely like to look at what is happening in men versus women in COVID. We know how severe it is, but we need to go deeper into the pathogenesis. What are the immune phenomena? How much is the thrombotic risk? Men versus women. We need obviously well stratified subsets with accounting for the other environmental influences. And yeah, we will like to look at the outcomes and treatment, um, how we can treat them differently, because this is something of great relevance, especially the vaccine efficacy. So if women are more immune, then it may also mean that now the IgG responses people are showing that at 3 months post COVID, your IgG wanes.
Yeah,
So we don't know how different that is in
yeah,
women. And in Italy, they were talking about COVID pass, like you check
yep.
your IgG and then you're out in the open that okay, I'm now immune. Although we have few reports now coming up of even like people getting infected by a different strain, but that's the exception rather than the rule. So this is something which could really be transformative if women are more protected, even post-COVID. So something to look at in the times to come.
Yeah, definitely. We don't have enough information yet because obviously, when a vaccine comes out, there has to be a prioritization on who gets the vaccine first. Because for a country of 1.3 billion people, it is nearly impossible to vaccinate everyone because there won't be, enough vaccines produced in Canada and US and all. That is the conversation that who should get the vaccine first. Whereas in India, it might be who's the one who can afford to buy it first. But I think
Yes.
we have to keep the larger community in mind. Thank you so much, Dr. Gupta, for investing your time. That was, I think, very interesting because it does have clinical implications. So, is it that in the future we may be treating women with hormones and maybe men with hormones as well once those studies come out? Whether the anticoagulation is going to be different in women versus men, whether the drugs that are used for COVID-19 whether they may be different in at least in terms of dosage or even the type of drugs versus in men versus in women. A lot of interesting things that will come out. Maybe something will come out which we haven't even thought of yet. So
Yeah.
thank you very much.
Thank you. Have a good